Hello, I am Sarah Jane. I am live here tonight from the Rehab Hub here I'm over in the Southside Kinning Park clinic, and I'm a musculoskeletal podiatrist. That means that I specialise in things that affect your muscles, your ligaments, your tendons, your bones, and primarily injuries in that. So, podiatrist is somebody who specialises in the lower limb, so primarily from the pelvis down. And we're also well known for being very, very specialised in the feet. So I wanted to talk tonight to you about diagnostic ultrasound, and this is something that we recently brought into the clinic. It's something I started my journey, my postgraduate certificate training of this last year at Glasgow Caledonian University. And this training was as part of my PhD, which is primarily focused on rheumatoid patients. And as part of that PhD, I'm basically going to be scanning a large data set or a large group of a big cohort of patients who have got rheumatoid arthritis. And we use the ultrasound for disease monitoring. And that's something that a lot of the rheumatologists do, is to monitor possible disease progression, changes in the joints and in the synovial tissue. And this is something that I will be doing as part of my PhD. But I digress. Basically, I needed to do this training to allow me to be able to do this for the study for my participants, essentially, so that I could scan them. Now, I want to, if I can find my foot, where's my foot gone? We'll grab this little foot. So, lots of people will come into us. Now, I also, as part of my ongoing mentorship and own self-development, I have a fantastic mentor, Dr. Lisa Wright, who I work with every Friday morning over in the Queen Elizabeth University Hospital. And over there, primarily all feet over there. In my own private practice clinic, I will see patients from foot, knee, hip, lower back. Really, those are my kind of main areas. Above that, we'll usually send you over to see our physiotherapist. And we have that within the Rehab Hub as well. But my area is definitely the lower limb. So lots of patients will come and see me for foot pain. And this is definitely my area of my happy place. So some of the things that diagnostic ultrasound can do is really allow us to look inside the foot. So if you look at this is the bones of the foot here. So we can look at the top of the foot, look at all the bony areas, so all the different joints within the foot, the plantar aspect of the foot as well, so underneath, and really just be checking, how does the bone look? What's the cortex of the bone looking like? What's it like inside? For example, this would be your first metatarsal phalangeal joint. So what the joint synovium looks like, what the articular cartilage looks like, what the ligaments look like. So it allows us to look at all of those structures chair side. So what that means is that when you're in, we can scan you there and then. And the great thing about ultrasound is that it can be a dynamic assessment. So what we mean by that is that you don't have to lie or sit still. We can actually move structures. So say, for example, and the other day I was actually scanning, I scanned two ATFL ligaments. So essentially that would be like, see if you've sprained your ankle. So it's called an inversion sprain, so the ankle coming in. And one of the most common ligaments in your body to sprain would be your anterior talofibular ligament, so just up here. And we can see if that's been, if it's been ruptured. We can see if it's lax, so we can actually scan that in real time and actually move your ankle joint about. So move that into that inversion and eversion motion and actually see how that's impacting the ligament as well. So we can test and see things right there and then. And then there's some ultrasounds that allow you to check the elasticity of the tissues that you're looking at as well. So it's pretty cool. So I thought tonight what I would do is give you a little look at ultrasounds. Now, I know it's not always the easiest. So I've got my machine here. What you can see here is the ultrasound machine. And this is what I will be, I suppose, driving when I'm looking at a patient. And then over there, we've basically got the image that's on the machine that then goes up into this big TV screen. Now, for me, a big part of, I suppose, my values is patient education, making sure that you know and know what we're doing and what we're up to. and we can show you real time what we're seeing. And that kind of comes, I'm a great believer, my master's is in public health, so I'm a big health advocate and making sure that you get ownership of your health and that you understand what's going on and we're not just doing stuff to you and looking. And that's something that I do over in the Queen Elizabeth on a Friday morning as well. We don't have like the big screen over there to show you, which, yeah, this is quite a bit of a luxury to have that. But over there, what we would do is take lots of pictures. We take lots of pictures here as well. And then we go through those images after with you so that we can explain what's going on. So any practitioner should be doing that anyway, making sure that you're understanding what the findings mean. And that's the great thing about diagnostic ultrasound. You've generally got that diagnostic thing that you've got that diagnostic tool there and then where you can actually see exactly what it is. So I thought we'd go through a wee bit about, what ultrasound is, what it's good for, what we do with this. Now, ultrasound, primarily most of you will recognise, maybe you've seen machines like this before, maybe you've had a baby, but certainly maybe the parents that are watching this, and you would have had your 12-week scan, right? So it would be an ultrasound that you would get for the scan. Now, the probe that they use is different to this one. So this is what's called a linear probe. So the actual machine will be exactly the same. So the actual ultrasound machine probably will look something very similar, but the probe will look different because we're scanning different structures. So for me, I scan musculoskeletal conditions. I don't scan babies. That's not part of my remit. But essentially, this probe, you can see how it's nice and flat. This is what's called a linear probe. And then we've got this kind of ML 6 to 15. So it's just telling me the frequency. So it tells me the depth that I can go to with this probe. So generally when you're scanning musculoskeletal structures, you're not looking as deep as a baby would be, or where a liver is, or a kidney, or any internal organs. And some clinicians, that will be within their remit where they're scanning. So you might be going for a diagnostic ultrasound and they might be looking at for kidney stones or something. They might be looking at your kidneys, or they might be looking at your liver, or so that wouldn't come under musculoskeletal, which is where I sit. So musculoskeletal would be stuff to do with ligaments, tendons, bones, bursa, these kind of things, not livers or any of those kind of things. But it's the same machine. Just this will look different. So this is what's called a linear probe, and this is primarily for musculoskeletal things. And that's because of the frequency that this can go to. So when we look at things that are much more superficial, we need to have what's called a higher frequency so that we can get a better image of those structures that we're trying to look at. Whereas if we're looking at deeper tissues, we need to have a lower frequency. So the transducer that somebody maybe that was a sonographer scanning fetuses, then they would have what's called a curvier probe, and it would be looking somewhere around like kind of maybe 4, 3, 2 frequency, whereas the lowest this one goes to is 6. So it's still quite superficial because it goes as high as 15. So pretty superficial structures. I don't have here, but you can also get the little hockey stick probes. So for looking at some of the phalanxes, so some of this really small structures, I just really like this one. So if I was wanting to do like fingers and toes, and I want to look at really small structures and really seeing that, then I'd want a higher frequency, and you can get, I think they're up to like 18 frequency. This one goes to 15. It works really well for most of the things that I need. I tend to work, it's actually interesting, with this probe, I tend to work primarily around about 8 frequencies for most stuff. So if I'm looking at plantar fascia, so I'm looking at the heel, or I'm looking at bursa, I tend to favour like the view around about 8. So that's the probe. Now, when we're looking at different structures, I'll see if I can get this over a wee bit so you can maybe see. We need to use ultrasound gel. So you need to have a gel basically to conduct. So if I get out, thought I had that ready, but there's none in that one. Get a cupboard. There's probably about 50 bottles of this in here, right? So ultrasound gel, I'm basically going to put that on, and then when I put this on, you'll see behind me that it basically just leaves this like kind of weird looking blob on the screen. Can you see that? So if essentially, if I just bring this over, hopefully you can see a wee bit better, and maybe bring you over, that might be a bit better for you. So what you've got is I've put my gel on, and if you watch the screen, you can see that I can tell there I am over that far side of the screen there. And then if I move here, You can see them over there. So you can see where we are. On the probes, if you're interested, you can actually see there's a wee line there, and that tells you what side's left and right. So we know that, I know that that's this side of the machine, and that's that. So I'm going to just for ease of this, I'm going to have a wee look. Let's just look at my finger. So if I just pop my finger on top of this, I can then start to see. So I'm basically just like that with my transducer on. And what we can see here is just at the top, I don't know if you can see my wee arrow, this area here that's brighter is the bone. So I can actually see the cortex of the bone of my finger, and I can actually see it wiggling about. Do you see that? I'm moving my finger and I can see that wiggling about. So I'll be able to see the bone. I can see the flexor tendons there as well, just above the bone there. So at the very top of the screen is the skin, and I could check the articular cartilage around that joint, so the bit that bends. Actually looks all right. There's a wee bit of irregularity, unfortunately. And I can check the joint capsule to see if there's any excess thickness or inflammation or fluid. Now, to check for inflammation, I would put a thing on called power Doppler. So see, for example, somebody had like really sore and it looked inflamed, then we can check for that. So yeah, nothing much interesting really there. Now, I'd probably tidy that image up a little bit. I can move my focus point up a wee bit. I'd maybe reduce my depth. I don't need to have all of that image there. I may maybe make that a bit bigger. If I go that way, in the wrong way, there we go, come down. Just make it a bit bigger. We're doing the width there. Essentially, maybe a bit better. So you can just change, and essentially what I'm doing there is optimize my image. So when we're doing this, we would always optimize the image. If you've ever been for a scan, your sonographer will be doing what they can to make the image the perfect image for them to see. And we can scan areas. If I just wipe this off, various different areas. So for me, the foot and ankle will be primarily my PhD project, and that's the main areas that I scan. So if we've got things like Morton's neuromas, plantar fasciopathy, Achilles tendinopathy, Achilles tendonitis, possible ruptures, midfoot osteoarthritis, any issues with ligaments, or we're trying to get a diagnosis, we're trying to get, what is it? Could it be? So, for example, probably the most common area that we scan is the plantar fascia. Plantar fascia and the Achilles tendon, I would say, are the two areas. I would say the plantar fascia more than the Achilles. So if I was scanning the foot, so obviously there's no tissue on this, there's no fatty padding, there's no muscles or anything. So if you imagine this is the heel underneath here, I would have my probe, and I'd generally be going to that kind of medial aspect at the point where the plantar fascia attaches onto, and I'd have my probe and I'd be looking at this. I'd look at my longitudinal view and also my transverse view. So I'm getting a full look at that tissue, and I can see the cortex of the bone. I can see the emphasis. I can see the point where the tissue attaches onto the bone, and I can see all I can follow that plantar fascia all the way up to its insertion point as well. So it's a really, really dynamic tool that allows anybody that's trained on it to assess the structures and actually get a diagnosis. We would then measure. So for example, if I was looking at the plantar fascia, anything kind of roughly, because we would look at your contralateral side and use that as your norm. But generally, the literature will tell us that anything over 4 millimeters would be seen as pathological in a plantar fascia. So if I measured your plantar fascia anywhere along the lines of it, if it was over 4 millimeters, I'm kind of almost thinking this is a bit thick. However, if both sides were kind of on the thick side, that may be your norm. So it's all relative to the individual. The Achilles tendon is also a personal favourite of mine, given that I have ruptured mine last year. And for here, what we can look at here is we can look at the Achilles tendon itself, always in two views. We would also be able to assess the bursas. So we have the pre-Achilles bursa, we also have the retrocalcaneal bursa. We can also check the Keeger's fat pad, which just sits more deeper in below the the tendon itself. So we can assess all of that. So we can be looking at, is this a tendinopathy? Is this a tendinitis? Is this a bursitis? Is this a combination of all of them? And I think that's really important, because when we start doing things like something I did today, like a steroid injection, for example. So today just this evening, I had a patient in, it was for a Morton's neuroma. We did an interdigital steroid injection. I'll show you what I mean by that. So interdigital, so basically between the digits, and it was between our second and our third digit, so just in here. She was getting this irritation of the kind of nerve, and she also had an enlarged fluid in that area as well. So we could essentially call that a bursa. So we did a steroid injection in there. And if I'm putting a steroid in, I want to make sure that the diagnosis that I've got is the right diagnosis. Now, she was getting other issues. So she had some pain around her plantar fascia. This was bilateral, both left and right side. And she was getting some issues around her calves and her Achilles tendon. And she was getting problems around her forefoot. So there's a lot going on, and only through thorough assessment did we get that proper diagnosis, that it then meant, right, well, now we then know how to manage this because we know what this is. So diagnostic ultrasound isn't the be all and end all. It's not like the magic wand that we should always pick up and use, but it's a tool that we can use to help us with our diagnosis. And we can also use diagnostic ultrasound to help with intervention. So if I, for example, say for example, you were doing a guided injection, so it was maybe into a joint space. So if you imagine, particularly the foot, right, there's lots of joints. A joint is anything that kind of bends and moves. Look at all these joints around this midfoot, right? And this area here actually, so up at the second TMT, so your tarsal-metatarsal joint there, is an area that is particularly, so sometimes it's just as it comes on to the cuneiform, so that kind of intermediate cuneiform coming up into the navicular. This can be a bit of a bugger. See this bit here, especially as we get older. So people can get this kind of overall forefoot pain, and it's generally around this area. And as a gentleman in today, and actually his was his third race, it was actually his third digit, and it was up at that lateral cuneiform up into the navicular. So the cuneiform navicular joint just up there was his main area, and there was advanced osteoarthritis that we recognised with that. So that helps us really pinpoint where the problem sits, and that allows us to do, it doesn't mean to say we always get in with a steroid injection, and that's not always first line, but it then just confirms what's going on. It puts that patient at ease. They know what's going on. It's not something else. It's not a tendinopathy. It's not a bursitis. It is what it is. It's that for that particular patient, it was osteoarthritic changes at the cuneiform navicular joint, and that then meant that we could really help that particular patient with lifestyle choices and changes to help with that pain and keep him on his feet pain-free. So that included footwear advice. He's going to be coming back. We're going to do a support through an orthotic therapy around that particular area, around that kind of midfoot, that kind of Liz Frank type area across there, that kind of joint area. And also, down the line, that you might need a steroid injection there. But right now, no, we can manage this quite conservatively. Other things that we can do there for that would be targeted laser therapy into that, and also magnetotherapy. There will be rehabilitation. Actually, what we saw with that particular foot was a lot of instability and weakness through the flexor muscles on the plantar aspect of his foot, and his extensor muscles, so the muscles on the top of his foot up into tibialis anterior, actually had mechanical advantage. So there was quite a little bit of work to do around rehabbing the foot as well. So it just allows us, it's a tool that allows us to get a more accurate picture of what's going on. And when we have a more accurate picture of what's going on, we then have a much more accurate management plan to help you get out of whatever pain it is and get you back in your feet pain-free. So that hopefully has maybe explained a little bit about diagnostic ultrasound. And this is something it's been on my bucket list, so to speak, for a while to do. As a musculoskeletal podiatrist, I wanted to be able to, well, of course, do my PhD. It's a major part of my study. As part of that, I haven't mentioned on this that I will be helping move along a new ultrasound scoring system. So how we score for the foot and ankle, because believe it or not, right now there isn't a consensus on how that is done. So hopefully some of my research will move that along and we get a better consensus, because only by us all doing things in a systemized way can we all compare against like for like. Whereas if we're comparing apples and oranges, it doesn't help anybody. It basically just, yeah, we haven't got a standardization, so it's very difficult to see something's this or that's better or not, because we don't have accurate data to go by, or we don't have data that's the same across the board. So that's part of my research as well, where I'll be, hopefully at the end of it, we might have a new scoring system, or at least I'll have moved that journey on just a little bit, that somebody else can then pick up through their next study to then move that along as well. So there's things always changing all the time. But yeah, we are based in, if you've not heard of us before and you've maybe randomly come on to me ranting on a Wednesday night, we're based in, I'm in Kinning Park at the moment. We're right on Portman Street, right above Hydropool Scotland, across from Sam's boxing gym. Is called Knox Boxing Gym. And also we've got, I'm looking over there because I can see the jiu-jitsu guys just now, just out the window. There's a grappling centre right across from us as well. Free on-street parking. Our Kinning Park place is great. And then we've also just recently opened up a West End premises. Now we have a little satellite clinic within the Western Tennis Club. We are able to do most things from over there as well, but it's a smaller clinic, and that's within the Western Tennis Club. And then more recently, just in September there, we opened the doors to the Rehab Hub. It's kind of like the Rehab Hub Light. We do most things. We've got 2 clinic rooms. One is currently under construction. We're building a new one as we speak. And over there, we're just on Crow Road, so right across from the West End Retail Park, which is great because you've got a couple of hours free parking in the retail park. So if you're coming for an appointment or a class, we've got all the reformer sessions over there as well. And we can do most things that we can do over here. We can do over there as well. We just can't do the full biomechanics assessments there because we don't have the Run 3D system. But watch this space, maybe soon. But pretty much everything else we can do. So from shockwave to injection therapy to laser therapy to Swift to all sorts, we can do over in the West End Clinic as well. So if you've got any questions or you may be worried about pain, please just reach out. We're always happy to help. If you're looking for a musculoskeletal appointment, you can phone us on 0141 363 0306. Booking lines are open usually most evenings till 8 o'clock. We can usually see you within a few days. So if you have any questions, don't hesitate to reach out, but thanks for listening.